Hi, so we have Dr. Alonzo here. Thank you, Dr. Alonzo, for coming out. I know that you're really, really busy. Just a super quick introduction. He was born here in the Rio Grande Valley. He earned his undergraduate degree from the University of Texas Pan American, and he received his medical degree at Baylor College of Medicine in Houston and completed his internship in general surgery and residency in urology at Jackson Memorial Hospital in Miami, Florida. He continued his training with a fellowship in surgical urologic oncology at the University of Miami, and he is fellowship-trained surgeon with expertise in the treatment of urological cancers. He specializes in robotic surgery for prostate, penile, bladder, and kidney cancer. Let's welcome Dr. Alonzo.
Good afternoon, guys. Sorry, am I on time? I think I'm on time. All right. I just had to leave the operating room, a bunch of blood and guts everywhere, and I'll put a Band-Aid on it, and I'll be back in 30 minutes. They said that they'll take care of it. Okay, no, I actually did leave the operating room. So I am Dr. Alonzo. From here, I'm the Valley's only urologic oncologist. That means I have the privilege of treating patients that have cancers of stuff that touches urine. So that's kidneys, bladders, prostates, penis, and testicles. Unless like you're a band member and you pee on somebody else's face, I don't do that. But today's presentation is on the prevalence of prostate cancer in the Valley and available services in clinical activity and research at DHR Health. So my goals for this talk, and number one is really to understand what the prostate is and what its normal function is. 2, to discuss the incidence of prostate cancer. 3, to review the current screening and diagnostic tests available. And number 4 is to understand the treatment options that are available to you if you are diagnosed with prostate cancer. Okay, so number 1, what is the prostate? So the prostate is a reproductive gland that sits between the bladder and the penis and makes a fluid that nourishes and protects the sperm, and it's about the size of a walnut. So the prostate, is this going to work? Yeah. So the prostate is this little organ here. This is your bladder, and this is penis and testicles. So just a little picture of it up close and kind of the stuff that is, what I work with and what I'm around. I actually removed a prostate this morning for prostate cancer. So this is kind of looking at you straight away, face to face. This is your rectum back here, your pooper. This is the bladder. This little beautiful heart-shaped organ is the prostate, and then the urine comes out through the penis. And looking at it from the side, these are the tubes that come from the kidneys, called the ureters. This is your bladder, and this is your prostate, and this is the rectum right here. Okay, and then this is your testicle. The testicles, I'm not sure how far in sexual education we have gotten, but the sperm is made in the testicles, and it travels up these tubes called the vas deferens, and it joins with these seminal vesicles, which actually make 80% of the ejaculate, and it forms into the ejaculatory duct, and then the sperm and semen comes out through the penis. So the prostate is an integral part in reproduction. So how does the prostate affect urination? Everybody's kind of heard about, your prostate's getting larger or you're too old. So in a normal male, your urine comes from the ureters, from the kidneys. It gets stored in the bladder, and then every 4 to 5 hours, the urine gets pushed through the urethra, through the prostate, and out through the penis. Now, in older gentlemen, or even sometimes younger ones, the central portion of the prostate, called the central zone, can get a little bit bigger, and then the urine that you make cannot get pushed through as easily through the prostate, not through the urethra. And so we call that an enlarged prostate, and the medical term for that is benign prostatic hyperplasia, so BPH. So what's prostate cancer? And so prostate cancer is any problem or any change in the DNA of the cells of the prostate, which become damaged and start to grow uncontrollably. And this may eventually spread to other parts of the body and can cause your untimely death. And it can really happen at any size or at any age of our male patients. And just kind of a schematic of prostate cancer. And I think it's interesting. Prostate cancer, I call it the cockroach of cancers. Unlike other cancers, it's just one area or one part. Prostate cancer, if you find one area that has cancer, it's like looking at a cockroach. You know that there's going to be other areas that are going to have cancer cells. And so prostate cancer specifically, we call it multifocal, meaning it's not really just in one area. You'll have it in multiple areas, and we know this from multiple studies looking at people who have died for other causes and we find prostate cancer in different little spots. So how common is it? So prostate cancer is the second most common cancer diagnosed in men, following only skin cancer. 1 in 9 men will be diagnosed with prostate cancer and in their lifetime, and ultimately 1 in 39 will die from the disease. So risk factors, it's actually more common in African American men. It's about 1.6 to 2 times more common in people whose ancestry can be traced back to Africa. And if we try to group them into different types of cancers, we kind of think it's more like breast cancer, meaning that if you have breast cancer, a lot of the times, and I think you had a talk this morning, you can control it with hormones. The same thing with prostate cancer. So symptoms. If you have cancer, what are your symptoms? In early stages, really no symptoms. It's something that can be caught, and we want to catch it early before it starts causing a lot of issues. If it starts to grow a little bit, the prostate can give you those same side effects of having difficulty peeing or changes in your erections. And then if the prostate cancer is even more advanced than that, it can cause, we call them systemic symptoms like bone pain, peeing and pooping when you don't want to. We call that incontinence. It can cause weakness, losing weight, night sweats, a whole lot of different whole body symptoms when it becomes extremely advanced. So you want to find this thing. And so we call that screening. And so screening for prostate cancer, generally if you're an average risk individual, we usually start at age 50. And then if you have a higher risk for having prostate cancer, so African American men, or if you have one person in your family who was diagnosed with prostate cancer at an early age, so brothers or fathers, then we say that that's less than 65. You start at about age 45. Now, if you have multiple people in your family who have had prostate cancer at a young age, less than 65, you start even earlier. So you start at age 40. And I know most of you, that's way, way, way in the future, but it creeps up on you real fast. And so we look at who gets diagnosed with prostate cancer and at what age. The average age of diagnosis of prostate cancer is actually age 66. The most common decade to be diagnosed with prostate cancer is age 65 to 74. But even in our younger guys, 35 to 44, we find sometimes some prostate cancer. And so it all depends really on your risk factors. So I've used the word screening before. So what does screening actually mean for prostate cancer? So specifically 2 things that are the most common to be performed by any doc, any family medicine person, is a digital rectal exam, and it's where your doctor feels for any abnormal areas or lumps or bumps on your prostate. And number 2 is a PSA, and PSA stands for prostate-specific antigen. It's a protein that only the prostate makes, and it's elevated or can be elevated in men with prostate cancer. There's other reasons for elevation of PSA, infections, riding your bicycle for too long, recent surgery to your prostate. Also, if your prostate is a little larger, it can actually secrete more PSA. But the most dangerous one to be concerned about would be the prostate cancer. So I said digital rectal exam, and I didn't really know if anybody knew what that meant. And so I've alluded to the fact that the prostate is right above the rectum. And so I think most of you have seen movies where somebody goes to the doctor and they get an exam. So that's what I do, basically. I do that, 100 times a day or something. So a finger goes into the rectum, and it's a procedure there, or a test that lasts for maybe 2 to 4 seconds, and you actually feel, and you can feel the peripheral zone of the prostate. I feel about 20% of men's prostate with my finger alone, but in that 20%, we'll find about 80% of prostate cancer. So it's a very easy test. I think, getting a mammogram and getting your boob squished is much, much worse. This is nice, and you already have a hole there, so might as well use it. And so, this is a super, super easy test. The other thing that I alluded to is your PSA, and PSA is more of a range. And so it's a blood test. You go to your Quest, or you go to a phlebotomist, and they get some blood out. PSAs, we consider a PSA greater than 4 to be abnormal, but it's a range. And so even in men that have a very low PSA, we find about 1% of men with a PSA of 0 to 2 that actually have prostate cancer. 2 to 4, which is also considered to be normal. We'll find 50% of those men to have prostate cancer, and then the higher you go, the more likely it is that you will have prostate cancer. So those are our two main screening tools that we use. There's other stuff that I use as well if I want to be a little bit more specific. We can use free PSA, which is basically PSA that's not bound to a protein. PCA3 is a urine test. PHI is a prostate health index, and a 4K score uses 4 different hormones in your blood, and it gives my patients a risk of having prostate cancer. And so we use all these things to try and determine your risk and the patient's risk of having prostate cancer. So specifically DHR, something that we've been doing here to try and advance the sciences is looking for biomarkers. And I think you've probably heard biomarkers already today. We take our patients who have already been diagnosed with prostate cancer, we collect the tissue, we collect urine, we collect blood, and we analyze it, the molecular structures, and we try to find some sort of a genetic component that is similar between everybody. And then we analyze that data, and we come up with a marker, and then the goal is to hopefully use that in the future for personalized medicine to test everybody and make it a nice and easy and quick test that's cheap and effective, and hopefully we'll be able to help our patients and future patients from having to deal with this terrible disease. Okay, so I said, we find prostate cancer. Well, how do you find prostate cancer? So we usually use a prostate biopsy, and this is a procedure where, again, we use the hole that's already there, and we put an ultrasound, and the ultrasound is small, but it goes into the rectum, and we measure the size of the prostate, and then we take samples. And I told you most of the time we'll take samples from the peripheral zone, which is the zone that is most likely going to have prostate cancer. And then before we do that, we'll numb it up with the same stuff that the dentist uses to numb everything up. And it's a procedure that takes maybe about 6 to 8 minutes. And it's really well tolerated, and we do it in our clinic. And we do about 10 to 15 a day, depending on the day. But it's a really easy, quick procedure. And we take those samples, and we send them to our pathologist. And the pathologist, which is the doctor that looks underneath microscopes at tissues and tells us, well, is this cancer or is it not? And if it's not, what is it? Is it inflamed? Is it totally benign? Or is this cancer? And then once you talk about cancer, you talk about how ugly those cells are and how different they are from normal cancer cells. And so for prostate cancer specifically, we use a Gleason grading, and that grade goes from 3 to 5. And the less aggressive or more normal-looking tissues are given a grade of 3, and then the higher grades and higher aggression of the cells and how different they look from the prostate cancer, from normal prostate cells, those guys we give them a score of 5. Now, when you talk about cancer, you also talk about stages of cancer. So stages of cancer really go from 1 to 4. And so for prostate cancer specifically, a stage 1 prostate cancer is a cancer that you find early, and that's what you really always want to find. Something early. It is in the prostate. You really can't feel it with your finger. The prostate otherwise feels normal, but when we take tissue samples, we found it. Stage 2 is when you can actually feel it. And so if you actually feel a lump or a bump, and if you have prostate cancer, you're more likely going to be diagnosed with stage 2. Stage 3 is when it starts spreading along the plane of your prostate and it's invading into other portions. So invading into the seminal vesicles, which I told you were right behind the prostate. And stage 4 is as bad as it can be, and that means that the prostate cancer has already escaped the prostate and is making problems elsewhere. So it's either invading into your bladder or it's invading to the rectum. It's bad news bears. And so stage 4 is as bad as it can get. So one of the things that I was born here and kind of an interest to me, there's actually not very many Hispanic urologists. And so kind of something near and dear to my heart is looking at prostate cancer, or cancer in general, but mostly prostate cancer for me in Hispanic men. And so this has been looked at a couple of different people. Hispanic men are actually diagnosed with prostate cancer at a slightly lower rate than our non-Hispanic white counterparts, 92 per 100,000 men for Hispanics, and non-Hispanic whites at about 102 per 100,000 men. Similarly, it also looks pretty good. The death rate for Hispanic men from prostate cancer is actually slightly lower. 15.9 per 100,000 men die from prostate cancer versus 18.2, 18.1 non-Hispanic white men. And then I think we all know in this room, or most people in this room, Hispanic really is all-encompassing. And, I look different from you guys, and you guys look different from each other. And so we've actually tried to look at the Hispanic population and subpopulations. And we actually find that Dominicans actually have a higher rate of having prostate cancer as compared to Puerto Ricans or Mexicans. And most people tend to think that the Caribbean islands, where there's a higher proportion of African ancestry, is actually the reason why Dominicans and some Caribbean Hispanic populations have higher rates of prostate cancer. So more than that, I looked at kind of our numbers for this talk ourselves, and I went back 6 months. And in the past 6 months, from May 11th to November the 4th, we performed 308 prostate biopsies ourselves. So I'm one of, I think, 6 urologists here at DHR that do these prostate biopsies. Out of 308 biopsies, we found prostate cancer in 159 men, and we found no cancer in 149. And you can look at it in 2 different ways. Number one is, geez, 1 out of 2 guys didn't even need that biopsy. I tend to think of it the other way. I think 1 out of 2 men who have been referred to us who have a suspicion for cancer, we're finding it. And so for me, that's a pretty high rate, and it really doesn't mean that we're doing that many unnecessary biopsies. It really means, I think, we're trying to stick to the guidelines, and we're really trying to find cancer, for our patients, for my friends, for your neighbors, for everybody here in the Valley. So, unfortunately, if you're diagnosed with prostate cancer, nobody ever wants to hear those words, but there are a lot of treatment options, and we'll touch on just a few. This is just the list, and we'll kind of go through the majority of them. There's something we call active surveillance. There's surgery, which is really what I do. There's different forms of radiation. There's brachytherapy. There's the normal or most common radiation called external beam. And there's newer forms that are coming out, some using protons and some using just really concentrated radiation called CyberKnife. And the newest treatment that we're really looking at are ablation treatments, trying to just kill that one tumor that we found. And again, controversial, because I told you if you find one tumor, you're generally going to find other ones if you look hard enough. So this is kind of a really controversial one, but people are really starting to look at it a little bit more closely recently. So we'll start with the first one. Active surveillance is a treatment option that's pretty good for a lot of men, for patients with really low grade, so Gleason 3 prostate cancers and small amounts of cancers. We think that most of those guys won't ever die from prostate cancer, so we just kind of watch them and we see if their prostate cancer is progressing. And so it involves monitoring them just to make sure that it's not getting more aggressive or higher volumes. I usually send all of my prostate specimens and biopsies that have cancer for genetic analysis to look at their chromosomes to see if they're really associated with an aggressive disease. I'll usually get a PSA every 6 months, and then I'll usually do another biopsy about 6 months to a year. And so you're just going to biopsy our patients every couple of months to every couple of years to make sure that you stay on top of it, to make sure that their cancer isn't progressing. So surgery, again, really what I do. Surgery is for removal of the prostate, and you also take the seminal vesicles, which are underneath it. So you cut right at your bladder, you cut at your urethra, you try and spare the nerves that are around the prostate, and then you have to actually sew the bladder back down to the urethra. So you disconnect your bladder, and then you reconnect it with stitches. And this is the room that I just left. This is kind of a typical operating room. Most of the surgeries are performed with the only robotic platform that's actually FDA approved, called the Da Vinci robot. And it's a whole room full of individuals. The robot is actually connected to the patient, and I'm sitting kind of in the back at a console and actually directing the robot to perform the surgery. Question? So it all depends. Usually, if it's done robotically, it's about 3 to 4 weeks. Yes, ma'am. It depends. This morning's was 2.5 hours, but it can take up to about 3 to 4 hours, depending on, sometimes my patients aren't exactly the healthiest people in the world, and they really like their tacos and their burritos or whatever, and they can be a little bit heftier. The thing about obesity is it actually makes surgery a lot more difficult. And so in more difficult individuals, it can take up to 4 or 5 hours. And I'll actually show you, I think, the next slide. That's a really nice segue. I hope I'm connected to the internet. Whoa. Oh, very cool. I didn't have to do anything.
You have been diagnosed with prostate cancer. Your doctor has recommended you to undergo a robot-assisted radical prostatectomy, or simply RARP. A radical prostatectomy is a surgical procedure where all of your prostate is removed. This animation shows how the procedure is done. RARP is carried out under general anesthesia. During a general anesthetic, medications are used to send you to sleep, so you are unaware of the surgery. When you are fully sedated, small cuts are made in your belly. Surgical tools and a camera are inserted through these cuts. The surgical tools are attached to the arms of a robot. These arms are controlled by the surgeon with a console, which is placed next to the operating table. The surgeon detaches the prostate from the surrounding tissue. The seminal vesicles, 2 small fluid-filled sacs next to your prostate that secrete fluid which partly composes the semen, are also detached. Sometimes the lymph nodes, commonly known as glands, are removed also. The surgeon will take care to cause as little damage as possible to the nerves and blood vessels surrounding the prostate. The prostate and seminal vesicles are removed from the body through one of the cuts in your belly. The bladder and urethra are now sutured together. Robot-assisted surgery provides a clear visualization of even the smallest parts in your body. A catheter is inserted in your bladder to help the stitched-up wound to heal. The catheter removes urine from your body. You will be wearing it for a period after you have left the hospital. It will remain in place by inflating the balloon at its tip. RARP is a major surgery from which your body needs to recover. You will suffer for a while from urinary incontinence, which in most cases is temporary. You may also suffer from erectile dysfunction after the surgery. Talk to your doctor about what can be done to overcome these complications.
That video costs like $2 million to make. I'm just kidding. Okay, so if surgery is not an option, radiation is the other option for prostate cancer treatment. One of the forms of radiation, which I actually thought it was really interesting when I first started my journey into learning all these techniques, is brachytherapy. So brachytherapy, usually for regular radiation, you're coming once a day, Monday through Friday for about 30 minutes a day, and you're laying on a table, and they're really just shooting concentrated x-rays at your prostate. So they can it's time consuming and it's hard. One of the options is actually taking radioactive seeds, and so it sounds like it's from a comic book. You take radioactive seeds and you implant them, along the prostate, really trying to find, you try to do it in a very linear fashion to try and get all of your prostate, and you implant them in a one-time dose, and then you go home and the radioactive seeds will kind of dissociate and will spread the radiation with time. And so it usually lasts about the 6 to 7 weeks that are normal, but the seeds become a permanent part of your body. So different risks and benefits to getting it done, but I just really thought that was an interesting technique when I was really first starting my medical journey. So we talked about prostate cancer kind of being contained and your options. Even if you have stage 4 prostate cancer or cancer that has come back, if you've tried to treat it, we have a lot of good options. Usually, like I told you about breast cancer, it's pretty susceptible to hormones, and the same thing with prostate cancer. In advanced prostate cancer, or we call it recurrent prostate cancer, we give hormones, and the hormones are basically an injection every 3 months, where we try to suppress testosterone, which is the hormone that really makes kind of the guys feel like macho and strong, and we suppress that. We take that away, and that really controls prostate cancer and controls it for a good amount of time. But just like most other cancers, it will eventually become resistant to the hormone therapy that we're giving. And so before, we call that term hormone-resistant prostate cancer. Before, we really didn't have that many options. We just kind of had chemotherapy and just general chemotherapy that we just kind of a Hail Mary last-ditch effort to try and cure your prostate cancer. But really in the past 5 to 10 years, we're coming out with a lot of really good treatment options, medicines and pills and injections that are really giving our men, even if they have really advanced prostate cancer, really giving them a good fighting chance to try and be around for as long as we can. And then there's a lot of new clinical trials that are looking at other forms of therapy to try and help these guys out. So in summary, the prostate is a reproductive gland that can become cancerous in 1 in 9 individuals, 1 in 9 men. We recommend screening at age 50 for most men at average risk for prostate cancer. And then those screening are the digital rectal exam and your PSA test. And then now more than ever, a lot of these guys have a lot of good treatment options with minimal side effects. Thank you guys for your time. Are there any questions? It's a very good question, actually, yes. So I alluded to those nerves that are right around the prostate. So having sex is actually really difficult. I mean, a lot of you guys think, it just happens. No, it's actually, it requires, your brain, it requires your nerves, it requires your veins, the arteries, and they all got to kind of work in sync. And then part of those things are those nerves that are right around the prostate that help with sexual function, help with your erections. And so anytime that you deal with surgery around those nerves, or anytime that you shoot radiation around those nerves, you have sexual dysfunction. And so yes, you can, about 50% of men after any form of treatment will have some form of erectile dysfunction 2 years after surgery or after treatment. So not necessarily. I think, again, having sex is difficult, and there's a lot of anxiety around cancer. And if you love, your partner, whoever it may be, and they're dealing with this cancer and they're dealing with maybe leakage of urine, it's really stressful for the partner as well. And that's really with a lot of cancers. And so, yeah, I mean, it can really affect the dynamic of a relationship. So technically or physiologically, no, but mentally and emotionally, yes. Any other questions? So I think there's a range, always. I mean, the guy that I did this morning was very normal BMI, BMI of 25 or 20. But, I mean, I did one last week. It was a BMI of 45, and he was almost 300 pounds. So I think I see a range. The guy that I did last week went to MD Anderson before he came to see me, and the guys at MD Anderson said, no, you're too fat. We can't do the surgery on you. So he came to me and he says, well, yeah. I said, yeah, you'll be my top 10, but if I didn't operate on people who are obese, I would never operate, just because of the area that we live in. We just have a very high rate of obesity. And then it's associated with a lot of different cancers. And so specifically, it's not a part of the topic, but kidney cancer. We found kidney cancer is higher. We find it in more people who are obese. And so it's a legitimate risk factor. So it hasn't really been found for prostate cancer. I see a range, but if you take me versus somebody like me in Houston, or Houston's probably a bad example, but like in Connecticut, my patients would be fatter. That's a lot of questions for after lunch. It's pretty good. Yes, ma'am. Testicular? Yeah, so testicular cancer is actually very common. And so it's actually probably would have been a better topic for high school students, honestly. So the age where you're most likely to be diagnosed with testicular cancer is in your youth. So from age 12 to about age 30. We find cancer in in that population. And then after age 32 to 35, you really don't see it. And then it kind of comes back at the age 75 to 78 to 80. But it is extremely common. And again, that's a very good point for my guys in this room. You're prime targets for testicular cancer. And so any lumps or bumps when you take a shower and you're feeling and you're washing, take a feel and make sure that you don't feel any lumps or bumps or any abnormalities. Make sure that it felt like it felt yesterday, because that is the higher rate for testicular cancer. And me personally, I do see a lot of testicular cancer here as well. Yes, ma'am. It actually has. And so I was probably so the Da Vinci has been around maybe about 15 to 20 years. And so in my training, I was probably one of the last, I'm really young, obviously. I'm very handsome. So I was one of the last people, I think, who did a lot of traditional surgery with my hands inside. And that surgery, I would have told most of my men, no way, you can't do it. Because when the pancita gets in the way, it makes the visualization really difficult and the surgery very dangerous. So robotic surgery has really helped in getting fatter guys a different treatment option. Also decreases blood loss and decreases recovery time. So traditional surgery is about 8 to 12 weeks that you have to really be off. But with robot surgery, it's about 3 to 4 weeks. And I do my kidney cancers. I'll do my bladder cancers with a robot, and the recovery time is really improved. So I do surgery. So 99% of my practice is cancer, but I still cover the hospital, and the hospital has a lot of traumas that we see. And if you're asking for cancer surgery, the youngest person probably about 8 years old. But if you're talking about a trauma, we do months old. And so it really all depends on what type of surgery. So because of the nature of my training, most are going to be men. Oh, I'm sorry. So the question is whether or not I really do only male bladders or if I do female bladders. And so I do kidneys, bladders, prostate, penis, testicles. So 3 out of 5 of those ladies don't have. And so just by nature of that, I do see more men. And then another risk factor for a lot of my cancers are smoking. And we usually see smoking a little bit higher proportion in men, but women are catching up, and you really shouldn't. This is not a good race that you want to win. You do not want to start smoking. And so because more men smoke, I see more men bladder cancers. But women have bladder cancer as well, and if their bladder cancer is bad enough that I need to remove a bladder, then yes, I will be doing that. Now, women have other bladder issues such as bladder dropping or coughing and sneezing and a little bit of urine coming out. I really don't do those surgeries or see those patients as much or ever really, but a lot of my partners do. And so if it's cancer, I'll remove whatever bladder I need to, male, female, whatever age. Yes. Most definitely. So the question was whether or not, just being in our culture, do men avoid going to see the doctor? And yeah, the answer is yes, and always. And it's really not just our culture. And I trained in Houston, I trained in Miami. A lot of other cultures have that, and guys really just don't want to ask for help, and they don't want to go and try and prevent. And it really is simple. Just get normal blood checks. Go see your doctor once a year. If you're higher risk, go a little bit more often. So it's not just the Hispanic patients. Is it worse? Maybe a little bit, but getting a guy to go to the doctor on a regular basis is hard, I think, no matter what culture you go to. We're dumb. Oh, there was a two-part question, though. I am from here, so I was born. So I've been around the medical field a lot. My mom was actually handicapped, and she actually had her bladder removed. And so seeing that and being in that kind of position to see her, and having to go to Houston and having to go to San Antonio to go get surgeries was very difficult. I went into medical school thinking that I was going to be a pediatrician. I really didn't want to do surgery. I thought it was gross. I saw what she had to deal with. But then being in medical school, I went to surgeries and I saw just how big of an impact I can make, or people make. And going elsewhere and seeing kind of the system, and kind of coming back and seeing my mom and my family and having to go to Houston, it really kind of hurt. And so during my training, I decided, let me try to find a place that would help me help you. And so DHR really has done that. And so I came back to offer a service that people really don't have to go to Houston or San Antonio anymore, specifically for my cancers. I think I stay up on top of it. I'm really good at what I do. I really love what I do. If you want to go to Houston and San Antonio, by all means, 100% go for it. But you don't have to anymore. And so that was really the draw, that I really am the only one of my type here that does these surgeries. Yes, ma'am. So it's a very good question. Man, these are really good. So the question was, did I do any engineering? And so the answer is no, I didn't have to, but I went to high school at the Science Academy. And so I did engineering because I knew that it was going to be a big base for college and a big base for medical school, just in general. And so I did engineering to try and prep myself. And I also did it to make sure that I didn't want to be an architect or something else. So it was a test, and I really hated it. I really didn't like engineering. I didn't like mechanical engineering. I didn't like electrical engineering. The human body is a miracle, and learning about it every day is a privilege. So I didn't have to do anything to learn robotics. I just had to know my humans and just practice. I did a lot of practicing, and there's techniques and there's machines that are practice. And so I'm not practicing on a human. I'm practicing on a video game, basically, that mimics a human. And so I did thousands of hours on that to try and prepare for my job, my career. Yes, ma'am. Let me go with that. In what, I'm sorry? Within my job, I think it's, and I've read about a lot of this, I really love what I do. I enjoy it, and I spend a lot of hours taking care of patients. My hardest thing that I still struggle with is saying no. And so my job is wonderful. I go to work happy. But my first 2 years when I got here, I was really neglecting my family a little bit too much. And so my wife had to take me aside and say, hey, listen, I know you want to be really good at what you do, but you got some little ones that really kind of want to grow up with you. So personally, that's my biggest issue. I went to bed at 2 in the morning practicing for this, and I woke up at 5 in the morning to go for a run before my surgery. So I can handle that part. But personally is turning off a little bit and making sure that my family is taken care of too. That was a little deep. Sorry. My motility surgery that I do, so I think it's a bladder removal. So your kidneys, usually you don't have cancer. If you have bladder cancer, you usually don't have kidney cancer. It happens. But your kidneys always are going to make urine. And so I have to remove a bladder, and then I got to connect it to something. And so what I usually connect it to is intestines. And so I'll cut a little piece of intestine, and then one of the options is bringing one side, connecting the kidneys to one side and bringing the other side to the pancita. Or I take more intestines, and I got to cut them all up, kind of fillet them open, and then I have to sew them into a ball, and then I sew the ball back down to the pee hole. And I do this for women and I do this for men, so that way you can pee somewhat normally and still pee out through the hole that you were peeing out before my surgery. It's a really complex surgery. It's 8 to 12 hours. So for me, that's my most interesting one. Yes? I think the hardest part of medical school, the question was, what was my experience with medical school? The hardest part about medical school is getting in. Honestly, it's tough. You're not going to have, nobody ever goes to medical school and like, yeah, it's going to be great. It's amazing because you get to learn what you're going to be doing for the rest of your life. But getting in is really difficult, and getting in starts now. So coming in here, doing this, I hope I'm a little, I'm not turning you off to the field, but, and going a little bit extra, going the extra mile, go to your volunteering. You really got to get good grades, and that starts yesterday. So if this is an option for you, or if you think that this is interesting to you, you're probably a little bit late. You got to, really kind of tune it in, focus on it, because getting in, there's thousands and thousands of applicants, and, they only take, so my class was 150, and 10,000 people interviewed to go to the medical school. So getting in is hard. Once you're in the medical school, it's frowned upon if they lose students. And so they'll do whatever they need to do. They'll get you tutors. So medical school is hard, don't get me wrong, but getting in is harder. Yes, sir. So the question was, chemotherapy affecting reproduction, and the answer is it does affect it. So for most of my guys who are going to get chemotherapy, and chemotherapy is more common in testicular cancer, I always recommend that they sperm bank. So you collect sperm and they cryo-freeze it, because your sperm quality will never return to normal. Yes, you can fertilize somebody. Yes, the baby could potentially be healthy, but then the counter is true. There also is the possibility that the baby can be abnormal in some form or fashion. So anybody who's going to get chemo with me, get sperm banked, or at least the option to sperm bank. Yes, ma'am. What was the question? I'm sorry. Oh, I was top of my class. I was salutatorian. Yes, ma'am. Have I ever messed up during my surgeries? I can honestly say no, because when I'm in surgery, and I made sure, and I told them, if I'm going to be in surgery, I'm going to be in surgery. Everything went beautiful today. Have there been complications from me, focusing and trying to do my very best job? And even though I do my very best job and I'm focused and I'm not distracted, bad things sometimes can happen. But me intentionally saying, whoops, no, it's not going to happen. Yes? Uno más. My mom. Personally, my mom. Most definitely. There's a lot of really good people, but she's top. Okay, last one? Or last, what? No. Uno más. It's got to be really good. Okay, that was a good one. I would have ended really nicely, I think, on that one. I do. If I drink too much coffee, I get shaky. So I don't drink any coffee when I operate. Practice. And one of the best surgeons that I've ever seen had a real bad tremor, but he timed it. And so he knew exactly when he was going to shake, he knew it, and he would throw the stitch with the shake, and he'd tie it with the shake, and he knew exactly how much pressure to put. Probably one of the greatest surgeons I've ever had the privilege of being with. So just because you shake, everybody shakes. You just got to learn how to control it, and you will. Okay, that was my time. Thank you, guys. I really appreciate it.